This podcast is brought to you by the hemoglobin electrophoresis machine. This isn't just an instrument, it's a finely tuned molecular talent show where your patient's hemoglobin proteins struck their stuff across an electric gel. We're here to see if hemoglobin S decides to take center stage with its notorious slow-motion strut, or if hemoglobin F overstays its welcome from childhood. It's truly a fascinating spectacle of charged particles, revealing whether your red blood cells are carrying the standard issue oxygen delivery system or a peculiar genetically inherited jazz ensemble.
Welcome back to the deep dive. Today, we're really plunging headfirst into a critical area of hematology, especially, for anyone working in the medical lab. We're talking about the anemias of hemoglobinopathies. We've got some great source material here to guide us, really aimed at giving you those actionable insights.
Yeah, absolutely. Our mission today is to properly unpack the pathophysiology and, just as importantly, the critical laboratory testing aspects of these inherited disorders. Understanding those connections, between the gene, the cell, and what you actually see on the bench, that's just paramount for accurate diagnosis and, ultimately for good patient care. And this deep dive is definitely tailored for you, our colleagues in the medical laboratory.
Okay, so let's jump right in then. We'll start by exploring what hemoglobinopathies actually are. Then maybe a quick refresher on how normal hemoglobin works.
Good idea, the baseline.
Exactly. And after that, we're going to zoom right in on specific structural variants, things like hemoglobin S, C, and E. And we'll link those, those tiny genetic defects, directly to the clues you spot on the blood smear and on the lab bench. This is where it gets really interesting, I think.
It really is, because for medical laboratory scientists, recognizing those sometimes subtle clues and really grasping the why behind the what isn't just about spotting an abnormal cell, right? It's about connecting the dots from that single gene mutation all the way to the patient's symptoms and, crucially, to those definitive diagnostic findings that guide treatment.
Okay, so let's start with that foundational question. What exactly are hemoglobinopathies? Our sources define them as, a pretty large group of inherited genetic disorders. The core issue: abnormalities either in the structure or in the synthesis of hemoglobin, HGB.
That vital protein.
Right. And the root cause, it all boils down to mutations in the genes encoding the globin chains: alpha, beta, gamma, delta, those building blocks.
And if we sort of connect this to the bigger picture of inherited anemias, these disorders tend to fall into two main buckets. First, you have the structural hemoglobin variants. That's mostly what we're digging into today. Here, the hemoglobin molecule itself is physically abnormal because of, usually, an amino acid swap. It changes its function or stability. Think hemoglobin S, hemoglobin C.
Right, the classic examples.
Exactly. The second category is the thalassemias. That's different. It's about reduced or even completely absent synthesis of one or more globin chains. It leads to unbalanced production. Both are critical, definitely, but our sources today really focus hard on those structural variants.
What's really striking, I think, is their global distribution. Our sources point out just how prevalent they are, especially in populations from Africa, the Mediterranean, the Middle East, Southeast Asia.
Yeah, that geographic link is so important for the lab.
It absolutely is. It's not just trivia, it's a diagnostic clue. It should immediately raise your index of suspicion, based on a patient's background. And clinically, the impact varies wildly, from completely asymptomatic,
like some traits,
exactly, to severe, even life-threatening conditions. It really depends entirely on that specific mutation.
Okay, so before we get into what goes wrong, maybe let's quickly review the normal blueprint. What's normal hemoglobin supposed to look like? Hemoglobin, HbA, it's that essential protein inside our red blood cells, the RBCs. Its main job? Oxygen transport. Can't live without it.
The delivery system.
Precisely. Structurally, it's a tetramer, 4 parts. 4 globin chains, usually 2 alpha-like and 2 beta-like in adults. And tucked inside each globin chain is a heme molecule. And right in the center of that heme, an iron atom, Fe2+. That's the exact spot where oxygen binds. A really elegant design.
So how does that elegant design translate to what you actually measure or see in the lab?
Well, when you analyze normal adult hemoglobin, the vast majority, like 95 to 98%, is hemoglobin A, HbA. That's 2 alpha and 2 beta chains.
The workhorse.
Definitely. Then you've got a small but important fraction, hemoglobin A2, or HbA2. That's 2 alpha and 2 delta chains, usually around 2 to 3%. And finally, there's hemoglobin F, HbF, fetal hemoglobin. 2 alpha, 2 gamma chains, dominant in fetuses, obviously, but in adults, normally less than 1%.
So these percentages, HbA, A2F, these are the benchmarks, right? What we compare against when we suspect something's off.
Exactly.
So now let's get into those specifics. Let's start with probably the most famous one, hemoglobin FS. The cause of sickle cell anemia, HbS, comes down to a single point mutation, just one change in the DNA code for the beta-globin gene, which sits on chromosome 11. Specifically, valine gets swapped in for glutamic acid right at the 6th position of that beta-globin chain. So beta-6-glu-val.
Seems like such a tiny change, doesn't it? Beta-6-glu-val.
Tiny change, massive consequences. It's like swapping one tiny logo brick for another with completely different properties, and suddenly the whole structure behaves differently under stress.
And yeah, this is where the real drama happens, clinically speaking, under low oxygen conditions. Think intense exercise, dehydration, high altitude, infection.
Any physiological stress, really.
Right. These abnormal HbS molecules, they start to polymerize. They literally stick together, forming these long, rigid fibers inside the red cell. And that distorts the cell, forces it into that classic crescent or sickle shape.
Which is where the name comes from. And these sickled cells, they're rigid. They're not flexible like normal RBCs. And that leads to two huge problems. First, vaso-occlusion. The rigid cells get stuck, block small blood vessels. That causes intense pain, cuts off oxygen to tissues, ischemia, and damages organs over time.
Excruciating pain crises, yeah.
And second, hemolysis. These misshapen and damaged cells get destroyed prematurely, mostly by the spleen, leading to a chronic hemolytic anemia. So thinking about the patient's experience, what do we typically see in what brings them in? Well, you have sickle cell trait, HbAs. That's the heterozygous state. One normal beta gene, one HbS gene.
Usually asymptomatic, mostly.
Mostly, yeah. Our sources say usually asymptomatic, maybe some issues like hematuria or splenic infarcts under a really extreme stress, but generally they live normal lives. But then there's sickle cell anemia, HbS-SS, homozygous, 2 HbS genes, and that is a severe chronic hemolytic anemia. It's marked by those devastating vaso-occlusive crises we mentioned, plus things like acute chest syndrome, strokes, chronic organ damage. It affects almost every system.
Okay, so when a patient presents maybe with that history or those symptoms, the big question for us in the lab is, what are the key findings? What do we look for? Your starting point is almost always the CBC, the complete blood count. In HbSS, expect the hemoglobin, HgB, to be low, often quite low, maybe 6 to 8 G per deciliter. Hematocrit HCT also decreased. MCV, the cell size, can be normal or slightly up, but here's the key thing. The MCHC, mean corpuscular hemoglobin concentration, is often increased, often over 36 G per deciliter.
That increased MCHC is a really useful flag, isn't it? Even before you see the shapes.
It really is. Indicates cellular dehydration, essentially. You might also see elevated WBCs and platelets, especially during a crisis. Then you absolutely have to look at the peripheral blood smear.
The visual confirmation.
Exactly. This is where you see those unmistakable sickle cells, the drepanocytes. Seeing those is highly suggestive. You'll also often find target cells, Howell-Jolly bodies, those little nuclear remnants that show the spleen isn't working well. Polychromasia indicating young cells, maybe even nucleated RBCs if anemia is severe.
And the reticulocyte count?
Well, it'll be high, often way up, maybe over 10%. That's the bone marrow trying furiously to compensate for all of the red cells being destroyed. And then the definitive test, hemoglobin electrophoresis, or HPLC these days often. This separates out the different hemoglobins. For sickle cell trait, HbAs, you'll see both HbA and HbS, roughly 50 to 60% HbA, 35 to 45% HbS. But for sickle cell anemia, HbSS, it's almost all HbS, like 80 to 95%. You'll also see elevated HbF, maybe 5 to 15%, and critically important, HbA is absent, no normal adult hemoglobin. That absence is key for diagnosing HbSS.
That absence is the clincher.
It really is. And don't forget the sickle solubility test. It's a quick screen. It'll be positive if HBS is present, but remember, it's just a screen. Positive in both trait and disease doesn't tell you which one.
Right, so diagnosis really hangs on putting it all together. Clinical picture, that smear morphology, the electrophoresis results, maybe genetic testing to absolutely confirm it. And treatment, well, it's complex. A lot focuses on managing symptoms and preventing complications. Our sources mention things like hydroxyurea that helps boost HbF production, which interferes with sickling.
Which can really reduce crisis frequency, yeah.
Definitely, and newer drugs like L-glutamine or crizanlizumab targeting adhesion, plus managing pain is huge. Vaccinations, prophylactic antibiotics in kids are vital. Blood transfusions for severe anemia or complications. And then there are the potential cures on the horizon like stem cell transplant, HSCT, and increasingly gene therapy.
Okay, so moving on from the polymerization drama of HBS, let's pivot to another important structural variant, hemoglobin C, HBC, also a point mutation in the beta globin gene, also on chromosome 11, also at position 6.
Same spot as HBS?
Same spot, different swap. This time it's lysine substituting for glutamic acid, so beta-6 glu-lys. And the pathophysiology is different too. Instead of polymerizing, HBC molecules tend to crystallize inside the red cells, especially as the cells dehydrate. This crystallization increases cell rigidity, makes them less deformable, and leads to their premature removal, again mainly by the spleen.
And clinically, how does HBC present compared to HBS? Well, HbAC, the trait form, usually completely symptomatic, similar to sickle trait in that way. But HbCC, the homozygous disease state, it typically causes a mild to moderate hemolytic anemia, often with splenomegaly and enlarged spleen.
Generally much milder than sickle cell anemia, though.
Generally much milder, but still something you absolutely need to recognize in the lab.
Right. So what are the key lab findings for HBC? Let's start with the CBC again. In HBCC disease, you'll see a mild to moderate decrease in HGB, maybe 10 to 12 G per deciliter, and decreased HCT. MCV might be normal, maybe slightly down, but here's that echo again. The MCHC is often increased, just like in HBS disease, often over 36 G per deciliter.
Interesting that shared MCHC finding despite different mechanisms.
It is. It suggests cellular dehydration is a factor in both, even if driven differently. Now, the peripheral blood smear for HBC is quite characteristic, the absolute hallmark. Target cells, lots and lots of prominent target cells, often more than 50% of the cells.
Really striking morphology.
Very striking. And you might even see actual HBC crystals. They look like sort of rectangular or rod-shaped dense inclusions within the RBCs, especially visible after splenectomy. You can also see microspherocytes sometimes, reflecting that membrane damage and rigidity.
And the Reddit count?
Usually just slightly elevated, reflecting that milder level of hemolysis compared to HBSS. And finally, hemoglobin electrophoresis. For HbAC trait, you'll see both HbA and HbC, usually around 60% HbA and 40% HbC. In HBCC disease, it's overwhelmingly HbC, like 90–95%, maybe a slight increase in HbF, but basically all HbC.
Okay, so diagnosis here really hinges on that smear, all those target cells, maybe crystals, and then confirmed by the electrophoresis pattern. And treatment? Usually not much needed, right?
Generally, yeah, it's supportive, maybe folic acid supplementation because of the chronic, albeit mild, hemolysis. Splenectomy is rarely done. Maybe only a splenomegaly becomes massive or hemolysis severe, but that's uncommon.
All right, let's tackle one more major player. Hemoglobin E, or HbE, another point mutation in the beta globin gene, chromosome 11 again, but this time the action is at position 26. It's a substitution of lysine for glutamic acid at the 26th spot. So beta-26 glu-lys. What's really interesting about HbE's pathophysiology and super relevant for you in the lab is that it's kind of got this dual personality. The HbE molecule itself is a bit unstable, and this specific mutation actually messes with RNA splicing a bit, leading to a mild reduction in beta-globin chain synthesis.
So it acts a bit like a structural variant and a mild thalassemia.
Exactly. It bridges that gap, which leads to some unique features.
That's fascinating. So how does that translate clinically?
Well, for HbE, the trait, usually totally asymptomatic, or maybe, just maybe, a very mild microcytic anemia. The cells might be slightly small. For HBE disease, homozygous HBE, also typically just a mild microcytic anemia, maybe some splenomegaly, usually not a major clinical issue on its own. But, and this is a huge but for the lab, the really significant scenario is when HBE is inherited with a beta thalassemia mutation. That combination, HBE beta thalassemia, is incredibly common, especially in Southeast Asia.
Right, a major health problem there.
Absolutely. And the severity, it can range from quite mild, almost like trait, all the way up to transfusion-dependent thalassemia major. It entirely depends on the severity of that co-inherited beta thalassemia gene. Recognizing this compound state is critical.
Okay, so what are we looking for in the lab with HBE? Your CBC is key here because of that thalassemia-like effect. You'll often see decreased HGB and HCT, variable depending on trait, disease, or the compound state, but crucially, the MCV will be decreased. Microcytosis is characteristic, and the MCH will be low too.
So unlike S or C disease, where MCV might be normal, here you expect small cells.
Exactly. Microcytosis is a big clue for HBE-related conditions. Then the peripheral blood smear. What do you see? Again, target cells are common, and you'll definitely see the microcytes reflecting that low MCV.
And on electrophoresis or HPLC, how does HBE behave there?
On electrophoresis or HPLC, HBE trait will show both HBA and HBE peaks. HBE disease will show predominantly HBE, maybe with a tiny bit of HBF. But for that clinically important HBE beta thalassemia, you'll typically find HBE as the major component, plus significantly elevated HBF. The amount of HBA present depends on the type of beta thalassemia mutation, beta plus or beta 0. Seeing lots of HBE and HBF together is highly suggestive of HBE beta thalassemia.
Got it. So diagnosis relies heavily on that microcytosis on the CBC, the smear findings, and then sorting out the specific pattern on electrophoresis. Treatment? For HBE or simple HBE, usually nothing needed, right?
Correct. Usually nothing needed. They're very mild.
But for HBE beta thalassemia?
Well, that depends entirely on the severity. Mild cases might just need monitoring. Severe cases, they might need regular blood transfusions and iron chelation therapy, just like severe beta thalassemia major.
Okay, so we've walked through S, C, and E. Pulling it all together now for the lab, how does this translate into your daily workflow? When should those internal alarm bells really start ringing for a potential hemoglobinopathy? Well, clearly any unexplained anemia is a starting point, especially if it has suggestive features like microcytosis or signs of hemolysis like hyretics or bilirubin.
Or that high MCHC we talked about for S and C.
Exactly. Plus, a family history is a huge clue, or if the patient comes from, one of those geographic regions where these are prevalent. Africa, Mediterranean, Middle East, Asia. Those factors should definitely raise your suspicion.
Right, and when that suspicion is raised, what's your core toolkit in the lab? What's the first line of a diagnostic attack? It starts, as we've said, with the CBC and the peripheral blood smear. These are absolutely foundational. You're meticulously assessing RBC morphology on the smear. Are there sickle cells, target cells, spherocytes, crystals? What do the indices say? Low MCV, high MCHC. This initial visual and quantitative assessment is incredibly powerful. It guides everything else.
Your first big clues are right there.
Then comes hemoglobin electrophoresis, or HPLC. This is really indispensable. It's the primary method to separate and, crucially, quantify the different hemoglobin types, A, A2, F, S, C, E, and others. It's absolutely critical for nailing down the diagnosis of the structural variants we've discussed, and also for diagnosing thalassemias by looking at HbA2 and F levels.
And the sickle solubility test fits in where?
It's a useful rapid screening test. If it's positive, it tells you HbS is present. Quick answer. But again, it doesn't differentiate trait, HbAs, from disease, HbSS, or other compound states like HbSC disease. you still need electrophoresis for the full picture. And sometimes you might need more specialized tests, right?
Occasionally, yes. If the picture is complex or ambiguous, you might move to things like globin chain synthesis assays, though they're less common now, or DNA analysis, genetic testing to identify the specific mutations. That can be definitive, especially for prenatal diagnosis or complex cases. So, we've taken quite a deep dive, haven't we, into this really fascinating world of hemoglobinopathies. We've tried to connect those specific, sometimes tiny genetic defects,
Like that single base change in HBS.
exactly, to their really profound impact on how red blood cells function or dysfunction. And most importantly for our listeners, how all that translates into the distinct laboratory findings you actually encounter day to day. What's really compelling, I think, is seeing how those molecular changes manifest as things you can see under a microscope or measure on an analyzer.
Yeah, absolutely. And for you, the medical laboratory scientists listening, really understanding the why, the pathophysiology behind these anemias, it means you're not just identifying, an oddly shaped cell or flagging an abnormal result. You're appreciating the whole story that sample is telling. From that single gene mutation right through to the patient sitting in the clinic, it makes looking at that smear, interpreting those results, feel much more connected, much more meaningful, doesn't it?
It really does.
So, final thought to leave you with. What does all this mean for the future? We touched on gene therapy, personalized medicine. How might these ongoing advancements continue to shift the diagnostic landscape for these conditions? And maybe, just as importantly, how will your role as a highly skilled lab professional continue to evolve alongside these incredibly powerful new technologies and therapies? Something to perhaps mull over until our next deep dive.